Good evening, everybody. Before embarking for imaging in urology, perhaps some comments. First, general remarks about imaging in COVID times, because there are a lot of questions about this. There has been quite a lot of newspaper coverage and TV interviews that gave a bit the impression that chest CT is really the way to go to diagnose a coronavirus infection. And the reasons are quite simple. It's readily available. You have the results very fast. It takes 1 minute to acquire the image, and you have the result 1 minute later. And it also has a high sensitivity, and as has been reported, even higher than the PCR test or the nasopharyngeal swab test, which is true. But only in selected populations, so in the high-risk population, not in the general population. So this is a common mistake that we frequently hear. So we do not use chest CT for screening asymptomatic general population. This is, I think, a very important point that I want to start with. Then there are some good indications for chest CT. For instance, in those patients with suggestive clinical features of the COVID infection, and that's clearly the coughing and fever and flu-like symptoms. So these patients, they get the PCR test, but after that, it returns negative. So that's a problem. We know that the lab test, the PCR test, is very accurate. It has a sensitivity and a specificity for finding the coronavirus of about 100%. The problem is you can have a patient with virus somewhere in the lungs, in the throat, but the virus doesn't get on the swab. And then so the lab only finds what's on the swab. If there's no virus in it, then the result comes back negative. And this occurs in about 30% of cases. 30% of cases with a negative PCR, but who are actually false negatives. This is where a chest CT can help to find the correct diagnosis. There are also hospitals who that like to do a chest CT as a triage test in patients, again with clinical features of a coronavirus. But the PCR test, it takes some time. It can take up to 6, 7, 8 hours to get results. And then the hospitals do not want to mix the patients with COVID and those without coronavirus. So the CT then triages them, those with abnormalities on the CT scan. I will show you some examples. They can be triaged in a room with COVID. Well, this is an example where you see these smoky areas that are suggestive of a viral infection. Can we go back to the previous slide, please? Okay, and there's a third, well, a bit an exception. These are the patients who are asymptomatic but come to the hospital because of symptoms unrelated to COVID, like those with an acute retention, for instance. Well, if these patients do not have symptoms of coronavirus, but they do have a high risk of infection or comorbidity, like those with lymphoma or those with a geriatric profile. Also, acute pathologies that require surgery or intubation, and also those patients that come in with an unclear clinical history, like those with an acute stroke who are unconscious. Well, these can get a CT scan of the chest just to triage them and to try to find a coronavirus infection that was not detected yet. These are some early findings that you can see. So these smoky, patchy areas, the ground glass appearance, that's how we call them. And the next slide is a more advanced case where you see confluation of all that and really consolidation of the lung. This is a typical bilateral pneumonia. So this was in general about when do we use imaging to find these corona infections. But then uroradiology. Well, we have to balance between clinically important imaging, but also between availability of the imaging tools, because we need to have one CT, one MRI scanner just for those COVID patients. We cannot use them for other pathologies. And also in the waiting rooms, we have to separate the patients as much as possible. So this needs a good workflow. And therefore, we have to select patients that we can image. Now, one of the, well, the thing that we use is we do only urgent imaging. But then what is urgent imaging? Well, a good solution is that we do all exams that cannot be postponed for more than 12 weeks, and that on a somatic or a psychological basis. It's a working definition that is quite neat, quite interesting. While you have some clear examples, a patient with a renal colic or acute scrotal pain, you can't say, let's wait 12 weeks, that's impossible. Also hematuria, also those patients with a recently diagnosed tumor who need to be staged. This is really clear cut. Even a radiologist would see that this is an exam that is needed. But sometimes it's more difficult because we as radiologists cannot always define what is really urgent because we do not always have the full knowledge of the medical condition of your patients, also the history of your patients. We do not know that. We also do not know what your therapy plan is or what your follow-up plan is, what you are willing to do with that patient. And also you have your date of consultation. And now you do more and more teleconsultations. You get reimbursed for that. You take the phone and you do the consultation, but you want that the imaging is already there when you have the telephone conference with your patients. But we as radiologists, we cannot do this by telephone, of course not. But we do not know these dates. So therefore, urgency cannot always be determined by us radiologists. We need you for that. And we need, well, some common sense in that, in determining which patients need imaging and do not need imaging. Next slide. An example that I like to give is, well, it's for oncology because we have a lot of oncology in our hospital. And for instance, we continue imaging and we keep the appointments that have already been made to monitor all oncological therapy that is now ongoing or that will not now be started. So if you need imaging for that and the therapy, it can be radiotherapy, it can be chemotherapy, whatever, well, everything that is now ongoing will get imaging if needed. Also, if the oncological therapy has been recently completed, then the early follow-up will be done also. And then when there are studies, well, of course, studies have set time points for imaging. We will respect these time points, and these imaging studies will also be done. And then we have patients with symptoms, either clinically or biochemically, that can point at a recurrence, where also this recurrence detection is deemed something urgent and will be done. What we do not want to do are follow-ups of treated cancers years ago in asymptomatic patients. Okay, so no symptoms, the tumor has been treated 5, 6, 7 years ago, yearly follow-up, well, that can be postponed for a couple of weeks or a couple of months. And this is the scheme of follow-up examinations that you can find in the EAU guidelines. Well, the suggestion is that everything that is in the column of 1 year, this can be done. 2 years, that's a bit debatable, but starting from 3 years, 4, 5, and later, we will postpone these exams. So that brings me to my conclusion. So in general, I really want to stress this. We do not do population screening for COVID positivity. The gold standard there remains the PCR test. But we can do a chest CT scan as a triage exam in selected cases. Then for uroradiology, the do's are all the exams that are deemed urgent on a somatic or psychological basis, and also all the studies, we do these exams, and the don'ts are, well, actually all the rest then. So, thank you.
Geert, you said that sometimes in oncological follow-up, in patients that present for any other reason without symptoms may have typical COVID signs on a chest CT or a chest X-ray. Now, we receive now, since the day before yesterday, on a daily basis, messages in our mailbox from radiology in Leuven saying, ah, yes, your patient came for oncological checkup, and we see typical signs of COVID-19 on the chest X-ray, or a CT, sorry. Now, the problem now is, apparently those patients are, radiology department talks to these patients. What should we really do with these patients? Should we just say, okay, we see something on your scan. Should we make them come back to have tests, PCR and so forth? Should we keep an eye on them? Should they? Because they should be, it's good that we are warned because they have their examinations before the checkup consultation. So we should probably do at least only a phone or a video conference call with these patients to follow them up. So what are your thoughts on that?
Yeah, well, we do see that in about, let's say 10%, 10-15%. So these are completely asymptomatic patients. They do not know they have been infected. They may be in the prodromal phase 3-4 days before they get symptoms in the early phase. So it happens in about 10-15%. Be careful. That's not always COVID, so it's not really specific. It can also be something else. It can be the common flu also. But what you should do then is to treat this patient as a potential COVID positive patient and do the PCR test. So this patient needs the swab test, and he may have had one, but it could be one of the 30%, which is negative. So a second PCR test should be done, and it should be ruled out. If it continues to be negative, there are other tests like the multiplex test to look for all the tiny little animals that can cause all these nasty things on the chest CT.